Hello, everyone, and thank you for joining us at day 3 of From Classroom to Boardroom, a virtual event series addressing issues of race and equity in the workplace and efforts to support an inclusive economic recovery in Charlottesville, Virginia, and in communities across the country. We'd like to thank the United Way of Greater Charlottesville, the University of Virginia, and Virginia Tourism Corporation, as well as a number of community partners and collaborators for helping us bring this program to life. We're especially excited for today's session. It's titled A New Model for Emergencies. And with that, I'd just like to introduce our moderator, Dr. Jones-Lewis from the Equity Center at UVA, to kick things off.
Thank you so much. I'm sorry, I already did it right, had my mic on mute, but here we are getting started. So I wanted to introduce my colleagues first. We have Gabby Levitt of Cultivate Seville, who is here to speak on their behalf, and Morenike Oyedebe from the Helper Lab at the University of Virginia. We are here today because we want to talk about inequity and ways to approach emergencies that might serve as a new model that includes greater levels of equity. So in the Charlottesville, Virginia area, 14% of folks are African American. However, those folks comprise 18% of COVID cases and 40% of hospitalizations. This number becomes even more alarming when you look at fatalities, where they comprise 25% of all fatalities. Things are not much better when you look at the Hispanic community, which is only 5% of our population and accounts for 29% of cases and 17% of hospitalizations, with about 5% of those resulting in fatalities. And so just to be really simple, there is a lot of disparity. And what we see is a certain portion of our population carrying a very heavy load when it comes to COVID-19 and its implications. So with Cultivate Seville, the Equity Center sought to really look at this inequity and look at how we could service those folks who had COVID-19. And what resulted was a model for future public health crises. So I'm going to pass this over to Morenike, and she is going to give you some historical grounding.
Well, hi, everyone. It is an absolute pleasure to be here with you guys today. I think to kind of expand on what Dr. Jones-Lewis is speaking to is, the inequities that we were seeing, especially in light of COVID-19, particularly amongst, low income and minority communities. And a lot of these inequities that we were seeing with regards to COVID-19 and why these communities were being disproportionately impacted really relates to social determinants of health. And, some of the ones that really stood out, in the pandemic is, for example, discrimination with regards to residential segregation and redlining. So that separation, which people are being cut off from resources and access to, healthcare facilities and primary care doctors, et cetera, really plays an impact in some of the numbers, the staggering numbers that we were seeing. I think another thing is also educational attainment. With minority and low income communities not necessarily receiving, the highest degrees, that impacts the kind of jobs that people can get. And with that, many people as a result are working in jobs where they may be more exposed to COVID-19 just because they're in more maybe service industry jobs. And also there's that lack of flexibility where individuals are able to call out from jobs either because of financial reasons or because they just don't have that flexibility to do so. And I think that, in combination with all of these various factors, it really contributes to why we see the inequities and why people were maybe able to actually quarantine or not safely quarantine. And I think the wraparound services, that was one of the ultimate goals, was that once, an individual actually tested positive for COVID-19, that they actually would be able to receive the resources and services that they would need to safely quarantine, because many families, once they received that, meant that they couldn't be able, or they wouldn't be able to go, to work and, receive the money that they need in order to pay the rent and take care of their family. And so that was something that I think the wraparound services really aim to do, but I think that's something we'll kind of get into.
Absolutely. And so with this conference presentation, people were sent some information. One of those is an executive summary of the COVID-19 wraparound services evaluation. And it's really important to note that one of the things that that document seeks to do is to elevate and foreground community voices. And this is something that Charlottesville has struggled with in the past. So something that we really, really thought was of crucial importance. One thing that is that we decided as a group and as an evaluation team was that we needed to make sure that we were giving credit where credit was due. We are not going to name the organizations that we worked with because there are many. And because if you would like to know who they are, you can click on the link to the wraparound services full program evaluation or the executive summary that will allow you to really dig into who helped and what their roles were. It's also important for us to note that the wraparound services really grew out of some early work by some key contributors. And these are folks who were like early strategic partners. And those folks who we acknowledge in the acknowledgement section of the document were Mayor Nakia Walker, Dr. Wes Bellamy, Dr. Janita Richardson, Dr. Cameron Webb, Jackie Martin of Sentara Martha Jefferson Hospital. And you've probably heard that name many times here recently. She's helping to get a lot of folks tested. And also Miss Joy Johnson, who is a Charlottesville resident and chair of the FAR Public Housing Association of Residents. So we wanted to acknowledge those folks and also to acknowledge that there's lots and lots and lots of other folks who helped in really important ways. When we talk about the purpose of the program, why did we need, or why did the community need for there to be COVID-19 or wraparound services? What was the purpose of the program? I'm going to go ahead and have you have that in your mind as an overarching question as I ask Morenike and Gabby to respond to this one. Who were you able to serve? what did you do, and what needs were met?
Thank you, Dr. Jones-Lewis. It's great to be here and to be discussing this with you all. So specifically for who we were able to serve, we made a point to ensure that our wraparound services included both the individual who tests positive, as well as their family members or household members, to ensure that all impacted were supported by this program. So specifically before the official transition from our team holding the operations to the health district, the program served approximately 51 cases, which is 230 individuals, including 152 adults and 78 children. And since we've transitioned to the program being operated and homed at the health district, the program has served approximately 162 cases and 676 individuals, including 405 adults and 271 children. So in aggregate, from start to date, we've reached 213 cases, including 906 individuals. And in terms of needs that were met, we have been able to offer throughout the program food, including prepared meals, produce, and shelf-stable food, prescription medication support, financial assistance, hotel support, and PPE, sanitation, and cleaning supplies.
Yeah, that is really interesting. And you just listed out like a lot of things that people were able to be provided with. And I know that early in the program, people had other needs too, right? And so the program had to kind of shift and change to meet the needs that were presented with the cases. So what was the purpose of the program initially? Like, why were y'all like, yeah, we should probably do this? Did it just come to you in a flash of light? What were the driving factors?
I would say that the program had this overall goal of trying to reduce the spread of the virus, but also doing so in a way that we're addressing the inequities that exist. And with that, I think that the two main ways that as a collective, honestly, it was, as you mentioned, more than just Gabby and myself, but as a collective, working with many of our stakeholders, I think we had two ultimate goals, which is one, increase the amount of testing sites that existed. And then two, once people were able to get tested, and if they did receive that positive test, to ensure that they were able to actually safely quarantine. And to be able to safely quarantine, one, to make sure that they had all of their services and needs met so that they wouldn't necessarily have to go out into the community and go to grocery stores, et cetera, or, feel, I guess, maybe forced to, still try and go to work because their financial needs are not met and they know that they need to work in order to pay, their rent, et cetera. And so with that, we knew that the inequities that really existed are within the low income and minority communities and within the refugee population that really exists here in Charlottesville. And I think with that, we wanted to make sure that we were doing so in a very tailored way that was culturally tailored, that was tailored specifically to the Charlottesville community. So hopefully I'm not getting ahead of the questions that you have for us, but in terms of the testing sites, we worked with the community to know where is it that people feel most comfortable and feel most safe and would be most convenient for people to actually go and receive these tests. And I think some of the very first testing locations that we had were at schools, in churches. And I think that something to also note, and I think that what helped with the effectiveness of this program is that the community members were the ones really leading this initiative because they know the needs of the community best. They know what, they are the trusted voices of the community. They know what the community will be receptive to. And so to really follow in their lead and just take that and operationalize it into a plan that can actually get these resources out, I think was ultimately our goal.
And so I'm going to just repeat what you said, right? The community members lead, and we follow, right? And that is something that is really a change with this, as opposed to some other things that have happened in the city. I'm gonna do it now, and I'm gonna ask y'all about value. Like, what is the value added to the Charlottesville Albemarle community? And y'all can talk about monetary value. You can talk about trust. What is the value add for this program?
So one of the findings from the evaluation was that the cost for wraparound services was significantly lower than the cost of staying in a hospital, staying at a hospital for 3 days, either with or without insurance. So the average cost of a 3-day hospital stay for COVID was totaled at $73,300 out of network and $38,100 in network. But the average cost for wraparound services per person totaled $409. And so there's a stark contrast here between the cost of addressing inequities and addressing these issues upfront versus allowing them to go unresolved.
And I think that we kind of know that about healthcare, right? That if we can do things that are preventative and do things early, then it can not only help people to live longer and help people to have a better quality of life, but it actually costs less, right? And so, yeah, that is a really, really stark difference. $73,000, $38,000. And I don't know about you two, but for me, that would really, really put me in a place where I might have to look at being unhoused, right? Or really, really struggling to pay any bills if I had to have just a 3-day hospital stay. And we know that some people with COVID have had to stay in the hospital a month, right? And so, yeah, those are really, really good numbers. Thank you. Can you tell me a little bit more? Sorry.
Sorry. And I just also want to add another, value add to this is that I think we kind of touched on it before, but building that trust within the community and having the community lead this initiative. I think that it's important to address how institutions, even including the University of Virginia, has kind of played a role in some of the distrust that the community members face. Especially as research institutions, or Charlottesville having a lot of research institutions, many times it's people in the academic space kind of leading the initiative, and maybe not necessarily elevating the voices of community members. And I think that this was an initiative that not only gave back to the community and really addressed the needs of the community, but allowed community members to lead. And I think that, kind of going back to the monetary aspect of it, as many of us know, medical debt is one of the highest, or largest reasons that people go into debt in the US. And this is a program in which it didn't cost community members any cost to themselves. Of course, there was cost, generated with this program, but at least it didn't cost them anything. And rather, it just allowed them to, one, get healthy and to be able to eventually go back into the community and, function and get back to work as usual.
Morgan K, what hit me just now is when you said it allowed them to get healthy. And my immediate thought was it allowed them life, right? Like we are supposed to have life, liberty, and the pursuit of happiness. Like it allowed them to live their life and to be able to get healthy so that they could go back and continue to live that life. Thank you so much for that point. So I'm going to ask y'all, because we have talked about some really great things. So I'm going to ask y'all to tell me a little bit more about the program and some of the challenges. What were some of the challenges, and how did you mitigate those. So can y'all tell me first about some of the challenges related to testing and maybe case intake?
Gabby, you want to take this one or you want me to take this one?
You can go ahead.
Okay. So I guess to kind of start with testing, just to give, let's give an overview of the program just so that people know kind of the course of things. How the program, operated generally speaking is that individuals will be able to go to these testing sites and of course get tested for COVID-19. And then the results would of course go to, some of our stakeholders in the labs. And then, individuals will be called and be notified whether they test positive or not. And it was during that call, particularly the calls in which, people received the devastating news that they had tested positive, that the onus was on the, person on the other side of the phone telling them that they've received this test, to give them the information about the wraparound services, which is the part where Gabby and I, came into play, but to give them that number, and the community member then would call that number specifically to, request these services. And I guess we'll get more into how the case intake worked, but throughout it, they would speak to a navigator in which their needs would be assessed. Just so that it was tailored in terms of the services and the products that they were receiving. And then it would go out to them, in batches over, their 14-day or so quarantine. So to kind of get back to the testing aspect of it, as I previously mentioned, we wanted to make sure that we were going to locations where it was most convenient in terms of allowing people to get there easily, that it was in a location that, required the most need, and that we were working with community partners that knew that specific community best. And so we, like I said, the first few locations were at churches and schools, but later on it expanded to other locations. And I would say that in terms of locations, it was always trying to figure out what is, one, assessing where's the greatest need, especially during the early parts, of COVID-19 when this program was really taking off, is that we never really knew where the hotspots were going to be, right? A lot of it had to do with, predictions based off of just knowing how inequities tend to operate, knowing how, various social determinants of health are at play. But a lot of it was just kind of predicting, where do we think was going to be hard hit and where should we prioritize our resources in the testing locations first. But I think that, I guess in terms of testing locations at first, just due to our overall capacity being kind of small internally in terms of, organizing the wraparound services, it was, we weren't able to have as many testing locations. But of course, as time progressed, we were able to kind of increase the number of testing locations.
Yeah. I think that that is really interesting. And again, what popped to my head was transit, right? And so some of this would have been based on who can get to another testing site, or do we need to bring the testing sites to them? And I do know that Charlottesville is working hard to look at equitable transit, but I think that this really shines a light on why that is so important. You talked about just a minute ago, it was on the onus of people to they would get called and then someone said, you have COVID, and then they offered them services. Did you find that some people were like, what, I have COVID, and then they didn't hear anything else? Gabby, could you address that?
So yeah, I mean, Marinike was focused more on managing the case intake process. And so we only were able to develop relationships with folks who received the contact for us from their resulting physician, and then call us. So we were only receiving calls from the people who were willing to call us. However, we did change that later on in the program, which I'll get to a little bit later. But I'm happy to talk about the resource activation
I would
challenges.
love to
Yeah.
hear about that.
Okay. Yeah. Well, as you all know, we were providing support services, and that requires staff support, that requires all the resources that go into it. It requires the storage space um, to do so, as well as the communications and transportation and delivery of the support services. And so we really patched together collectively all of these different aspects of the program from different supports that all of our partners were able to provide. And so at various points during the program development and establishing the program, we had to navigate those limitations in staff support, those limitations in resources available, especially since it was the beginning of the pandemic, where we were all of our organizations were internally responding, as well as like collectively working together to respond to this specific piece. And so we developed mechanisms and ways to manage that, such as developing an inventory tracking sheet so that partners would be informed about what services and supports we could provide, so that there wasn't so that there was transparency and consistency when interacting and intaking community members. And then another aspect was the turnaround time, because we have deliveries that go out on Tuesdays and Fridays, and that's still going on. And so we set a schedule so that all of our partners could organize around those specific days, but that meant that specific families that might have called in, or individuals that might have called in a certain day, might not receive their support in a timely manner if it fell at a certain time of the week. And so that was a challenge that we had to navigate, but we did our best.
Yes.
And then Miranda, do you want to talk about the finances piece, or I can speak to that too if you'd like?
Yeah, I can go ahead and maybe incorporate that. I kind of want to kind of revisit the case intake part, because as Gabby mentioned, she really oversaw the resource activation aspect of it. So ensuring that people were actually getting, food, the PPE, finances, and, housing accommodations if needed. But, before we could, get to that point, we really need to assess what each household's needs were. Because as we mentioned, is that once a family member was tested positive, that meant that the whole house needed to essentially quarantine the people that were in contact with them. So that means we were not just serving those who received the positive result, but just everyone in the household. And so part of that was developing a survey that would really assess people's needs. So in that survey, it asks questions about, their food and any diets, dietary restrictions that they had, any medication that they were taking. We even asked about, the refrigerator size, just because, if we're giving a service, we want to make sure that it's actually going to be effectively used, and we're doing so in a very efficient manner. And I think with that, essentially, we wanted to make sure that people weren't just receiving 14 days worth of food, but couldn't hold 14 days worth of food in the refrigerator. And so with that intake process, I think something that we did not necessarily anticipate is who was going to exactly be calling us. And I think something that we quickly learned was that there was a language barrier. Many of the people that were calling us were a part of the Hispanic and Latinx community and spoke primarily Spanish. And so we had navigators who actually spoke Spanish that would then speak with them, so that language barrier was overcome. And so I think overcoming those kind of challenges and being able to adapt the program to needs as we saw them coming, as we saw them developing, even making sure that we had things such as diapers, which we never knew that we would need that, and like baby formula, for example, or we didn't think about it, I should say. But just thinking about those things, I think was important to the intake process and being culturally sensitive, that the food that we were also giving, for example, were tailored to what people actually eat in their homes.
Yeah, I was gonna bring up that part too. I know that there were some people who, because of maybe their culture or religion, ate a certain diet. How are y'all able to first of all even get that information and then to try to respond to it?
I'll speak to the first half and then let Gabby speak to the second half. So in terms of just assessing the information, we just asked them, about their cultural, like not cultural preferences, sorry, but food preferences. We would ask them what their favorite meals were. I think that was just the best way to do so without saying, is there a cultural like preference, food preference that you have, but just honestly, just getting to know people and what they actually like to eat and prefer.
Mm-hmm. And then from there, that information was communicated to the relevant partners who were involved in the resource activation piece of the program. So our meals provider, Harvest Moon, was able to utilize that information to inform the different dietary preferences and needs of the community members who are going through the wraparound program.
That is awesome. Thank you so much for that. So this started as really community members having ideas and really wanting to do what's best for the community at large, and then coming together and then getting stitched together in a way that was working. And then the idea was for this to expand, right? So I'm going to ask you now, Gabby, to talk about the transition to the Blue Ridge Health District.
Thank you. Yes. So we went from nonprofit collaboration to institutional implementation. And that was really important for this program to be operated from the health district, as they're the ones responding to very actively responding to this public health crisis. And we have a great partnership with them that had been developing from the very beginning of the program. And with their support, in November of 2020, the health district was able to hire a care resource coordinator who was dedicated specifically to managing the wraparound service program, which is formally known now as the COVID Care Support Services. And it was really great having that transition. They were able to automate some of the resource activation documentation process using their existing technologies to streamline the program. And we were really, the most important part though, is that we were able to really embed this program that was very equity centered into their COVID response, including allowing referrals from positive cases from the case investigation team at the health district that is communicating with everyone who tests positive to the wraparound team. And that was when the shift from folks calling in to a referrals model occurred. And so that way, the onus was no longer on community members that tested positive to call in, but rather to be reached out to through those processes. And yeah, that was a big transition. And we were also able to address some of the language barriers as well by tapping into the city's translation services. And we were able to accept text, call, and WhatsApp, as well as different forms of communication to open it up and make it more accessible in that communication style. And then do you want me to talk about the expansion of the program too?
I think that we're going to kick it back to Morena Kay to talk about the development of finances and how those needs have been met, and then we will transition back there. Thank you.
Yes, so finances has been a big topic, I think, just generally speaking, right, in terms of the economy and just in terms of individuals and how hard hit everyone has been. And I think that that was a large part of, one of the main resources I would say that was really requested during this time. And, at the beginning of the program, because like I said, we didn't know, how I guess how grave the need would be and kind of what the influx of the need would be. And so at first we were meeting people at their 100% capacity. So what they felt was needed in order to be able to pay their bills and sustain their households. And I think that one of the things that we noticed very early on is the fact that many of the families that we were serving had the additional responsibilities of taking care of their families that lived abroad. And that was something that we were very aware of, that comes with a lot of financial or additional financial responsibilities in addition to their family that is domestically here. Um, and we realized soon that that was not going to necessarily be sustainable, especially as, the numbers were increasing as the pandemic was, or as time was progressing. And so as time progressed, we had to standardize the finances moving forward. And so I think that there, it was of course still very helpful because we also learned that many people were able to get additional financial resources from other programs that were going on in the area. But, it is important to note that that was not necessarily available to everyone, or that everyone did not know of all of the additional financial programs that were going on. And so with that, I think that that was an area where, of course, with additional financial backing, we could have provided more moving forward. And something that I think with the expansion and the transition, which is why we were really pushing for them, working hard with partners to make sure that we could institutionalize the program, was so that there would be a more consistent influx of finances, and so that people's needs could really consistently be met. I will say there was one hurdle where it was getting the finances to people, because many of the people that we were serving did not necessarily use their or wiring it through like a bank account would not be an option, or giving a gift card would not be an option, because these people cannot go out during the quarantine, right, to utilize a gift card, for example. So it really oftentimes required, giving cash or finding another means that would be best for these families. So that was something definitely to also adjust to.
Yeah. Thank you so much for that. And you even mentioned like really growing this out to a larger scale helped to solidify it, as counterintuitive as that seems, right? So Gabby, can you talk about the expansion of the program to other spaces?
Yeah. So one of the original strategic goals of the program was to expand the Wraparound program beyond just Charlottesville and Albemarle to include support for county residents in the entire health district. So Louisa, Greene, Nelson, and Fluvanna. And despite the many obstacles that we were faced with as of this month, well, it's April now, but as of March, almost a full year after Wraparound program got started, we've been able to expand to provide support to the health districts, counties, specifically for PPE and sanitation supplies and food to Fluvanna and Greene. And Louisa's program is still in development, and Nelson's program will be available starting in April. So we were able to create a replicable model to expand across to the county localities, which is a very exciting milestone. And most of that work was due to transitioning to the health district and having the care resource coordinator, who is so awesome, take on that role and really be able to utilize the resources of the health district to do so, as well as all of the partnerships involved. And I will say too that the program is currently seeking donations or partnership support to provide more of those wraparound services to localities. And so if you are interested in supporting, I can drop my email and phone number in the chat for attendees to consider.
Yeah, thank you so much. I really, really like how you said moving the model, right? Because very, very often what we have is situations where we have magic, right? Like, oh, it worked here. That's awesome. But we wanted to work for all of these people because people in Charlottesville matter and people in Albemarle matter and all of those people matter, right? So that is really beautiful. And I did want to talk about maybe the thought of expanding even wider, right? So this is a program that was tailored to Charlottesville and then to the Charlottesville area, right? And the surrounding counties. How can the lessons learned be used to implement something similar in other communities?
Well, I hope that we don't go through another pandemic again. I will say that this is a model that in general can be used even once we move past this pandemic. The needs that people have are still present for various reasons, right? We've talked about kind of the long history of inequities that exist, both in terms of racial disparities, in terms of access to healthcare, and so in terms of just economic disparities. And so a program like this is a program that can be sustainable with the backing of of personnel and financial support. And so I think in terms of the lessons, I think something to really keep in mind with this program as it moves forward is that one, it should always be tailored to the community. And I think the overall infrastructure is something that can, have the longevity of being moved on, right? In terms of the services provided, in terms of, more or less the flow of information once we institutionalized it. I think that could be passed on, but I think the aspect that would always need to be tailored is so that it fits the specific needs of the community. So in communities where, let's say access to healthcare is a bigger concern, increasing the wraparound service where people are able to have transportation to get to and from their hospital visit. So I think there's different things that can just be tweaked and emphasized based off the community being served. And yeah.
And
Thank you so much. Go right ahead.
That was great, Miranda Kay. And I'll just add too that I think one of the reasons it was so successful here in Charlottesville was because many of the pre-existing relationships and groundwork had been laid by all the many partners having experience working together in different capacities. And the pandemic really brought out that need to collaboratively and collectively work together to share resources, share staff support, share processes to address the gaps that have been created by the inequitable systems and structures in our community and society at large.
I feel like everything we need to know we learned in kindergarten, right? Like if we share and work together, then it works. Yes, that part right there. So ladies, thank you so much. We are just going to wrap by telling everyone how they could request COVID care and thanking everyone who was able to attend today. And Gabby, if you will do that, and then we will be all done.
Absolutely. So the program is available for folks who test positive for COVID and are in need of support to recover and self-isolate, as well as their family members or household members. And so the main way to activate the program is through being reached out to by the health department within 24 hours after receiving positive results. And then and then you will be referred directly to the care resource coordinator who will begin that process. But if you haven't heard from the health department within 24 hours, you can reach out directly to the care resource coordinator at the number that I'll drop in the chat, via phone, text, or WhatsApp. And there's also Spanish translation for that too, if you'd like, and to share it with others as well.
Thank you.
It's a little wordy, but hopefully that's helpful.
Thank you.
Awesome. Well, thanks so much, panelists. Really appreciate you sharing this incredible program with everybody who's able to join us today.
Thank you so much for having us. This was absolutely an amazing time. It's always great linking up with you guys again to talk about this program. So thank you.
Awesome.
Always. Thank you.
And audience members, this was recorded and we'll be sharing via our YouTube channel. So if you want to pass along information about this program with anyone else, then be encouraged to. Thanks again, y'all.
Thanks.
So bye.